presentations demonstrate to you the great benefits that dynamic navigation has, and show you all the clinical applications and how this technology continues expanding and evolving and creating solutions to clinical challenges. I love these drone footage partaken by my husband, Dr. LaRosa, and I love it not only because it shows you a small glimpse of the beautiful place where we live in the Pacific Northwest, but because in my mind, it represents new beginnings, evolving techniques, and evolving technologies. This drone is the technology that has let us see horizons that before we were not able to see, but only with the very expensive cameras of maybe National Geographic. And yet today, we have this drone technology available to us. And that is why I compare this technology to dynamic surgical navigation. Because before we could only imagine doing navigated surgery in the operating rooms, maybe for craniofacial surgery, for neurosurgery, and for ENT. Yet today, we have this technology in our dental practice. And with it, I can very accurately and reproduce the accuracy of these real-time navigation when I place my implants. So what I like for you to learn today is summarized in three essential questions. It's what, how, and why. So what is dynamic surgical navigation? How does it work? And how can dynamic navigation assist us in all implant surgical procedures, from immediate implants to delayed implants, from singles to multiples, from transcrestal sinus augmentations to pterygoid implants, which Dr. Luigi Stefanelli will be presenting on his webinar, to partial extraction therapy. And this is all without the need of a static guide. I want you to learn the workflow through case presentation. And last, I want you to understand why. Why dynamic surgical navigation? What are the benefits? So what is dynamic surgical navigation? It is a computer-guided freehand technology that allows for highly accurate procedures in real time through your instrument's motion tracking. And how does it work? Well, it works much like a GPS, where your satellite is a MicronTracker camera or an optical position sensor camera that is tracking in real time the positions of those trackers that are placed on the patient and on the instrument that you're using. The video stream is then taken back to the computer, where the exact calculations of the location of those trackers are relative to the camera, and that is what you see in the screen. So your computer display is your GPS display, and your CVCT is your road map. So again, much like a GPS, but that of an aircraft, providing all three positional planes, the X, the Y, and the Z, in real time, resulting in very accurate procedures to our particular interest for the placement of implants. And we know as the technology continues expanding its applications, now in the field of endodontics, for the access of calcified canals and for the endodontic microsurgery, which I am also very excited to hear from both Drs. Bobby Nadeau and Dr. Paula Villa in their upcoming webinars, when they will share with us what they're doing in endodontics. So in my search to do things better for my patients, I have been exploring techniques and technologies through the years. And that search has led me to do things better for my patients. A perfect example is the transcrestal approach through the transcrestal approach that was first published by Dr. Summers through the osteotome-mediated technique. And we know that since that was published, and with the advent of techniques and with technologies, various procedures have been developed to access and to prepare and to elevate the sinus floor. I have been personally using the Hatch-Raymer technique and technology since 2008. And basically this procedure, you know, the osteodensification technique and technology, I started using it in 2018. So why am I combining technologies to a procedure that we all know so well and that has worked successfully since 1994? Well, for me, I was set. I was determined on changing the way I was doing this procedure for my patients. I wanted to improve their experience. I wanted to minimize the percussive forces of the mallet. And I also wanted to improve the infracture of the sinus cavity. So when we incorporated dynamic surgical navigation in 2017, I started combining these technologies, and it became the perfect synergy. Not only I was able to improve my patient's experience, but I was able to improve the accuracy of my procedures. So to expand on the literature, on the research that Dr. Mandelaris is very eloquently expressed to us and showed us last week in his webinar, when we review studies in the accuracy of implants, it is very important to compare publications and make a distinction between fully guided and partially guided to understand the real benefits of dynamic surgical navigation. So let's look at this. When we look at the mean entry point deviation, at the mean apical point deviation, and the mean angle discrepancy, we can see how study guides perform very similar to two of the navigational technologies, but they definitely overperform when we compare them to freehand surgery, which is very much expected. Yet when we compared all the navigational technologies, it is one of them that demonstrates and surpasses the accuracy at all levels. What is important for me here is to show you how from freehand surgery to study guides to dynamic surgical navigation, we are doing so much better for our patients. So let's now review the workflow through case presentation, where I will be able to show you how this technology continues expanding its application and creating solutions to clinical challenges. And through the case presentation, you will be able to see the great benefits of dynamic surgical navigation. So in our first case, I did a transcrestal approach. I am combining technologies, dynamic surgical navigation with the DensaBird technology for osteodensification. We know that osteodensification is the technique that we use to condense the bone both laterally and apically, which is going to minimize the need for bone grafting and also will improve the insertion torque of our implant. So in the first case, we will refer this patient so that we can provide to her first molar occlusion. I will present only the area of number 14 where the transcrestal approach was completed. So we first obtained the diagnostics. We have a CBCT, we obtain an optical surface scan, and with the optical surface scan, I will have our lab partner create an ideal virtual plan for the area of number 14. With the DICOM file from the CBCT and the STL file from the optical scan, I merge them into the navigational software. And you can appreciate that I have a residual bone height of 7.5 millimeters. So my virtual plan is at 6.5, so we can pursue the osteodensification. So we select the landmarks for navigation. The software requires that we select between 3 to 6 landmarks, staying as close as possible to the incisal edge. And after we have selected the landmarks, we're going to make our patient nice and comfortable. We will create an axis flap that is quite conservative. And we're going to initiate the preparation for the patient by providing to her the head tracker, which is optically marked, so it can be tracked by the MicronTracker camera throughout the surgery. We're going to calibrate, we're going to proceed to the trace registration, which is the initial phase of the navigation. And to do that, we have to calibrate our tracer tool. And we will proceed to do the trace registration. We're in full contact with the landmarks that we have selected, and we're tracing 100 points per landmark chosen, always in full contact with those teeth. So at this point, we're going to verify the accuracy of the trace registration. And this is a very crucial part. We want to make sure that the trace registration is accurate to assure the safety and, of course, the accuracy of the navigation. Once we complete the accuracy check, we're going to calibrate the drill axis and the drill tip of our drills, and we're going to verify the accuracy of that drill tip. And we want to do this in the different planes. We're going to go from the buccal, the occlusal, and the lingual to assure that safety, to assure the accuracy throughout the navigation. And we do this at every drill that is calibrated. So we start the navigated osteotomy, and we're going to start with a pilot drill. We're going at 1200 RPMs, fully irrigated. You can appreciate on the navigational screen on the left the deviations at entry, the angular deviation, and the depth indicator. One of the great benefits of the technology, we can change the plan within surgery with minimum delay to the procedure. And this is crucial for transcrestal sinus augmentation, as we need to advance 1 millimeter progressively into the sinus cavity. So we start the osteodensification, and we do this with the first densa, which is a 2 millimeter densa. We're fully navigating it. On the cross-sectional view, you can appreciate the real-time visualization of the sinus cavity, something we couldn't see or do with study guides or freehand surgery. Once again, I will change the virtual length of the implant as I continue progressing into the sinus cavity in order to condense the bone laterally and apically. And I continue with the densa burst sequence. We're going from the 2 millimeter to the 3 and the 4. You can appreciate the real-time verification of the restoratively driven osteotomy as we're doing the osteodensification. And you can see here that I'm only looking at the computer screen at all times. So after we verify the accuracy of my next drill, we continue with the densa sequence. And I'm concentrating my sight on that target view at all times. You can appreciate the video stream on the left of the screen that is happening as we're doing the navigational process. And here I want to show you how parallel we are to the occlusal fossa of that adjacent tooth and to the jaw curve when I'm only looking at the computer screen. This is the condensation of the bone obtained in the sinus cavity. I know that we all know that the literature demonstrates that we do not need to do a sinus graft for transcrestal augmentations. We're all different clinicians. I still like to do a bone graft on my transcrestal approaches. I combine that with biological materials. And I will use the densa burr in a counterclockwise, as is, the technology calls for, at 200 RPMs, no irrigation, yet fully navigated. And I am following at all times, once again, that target view on the left, concentrating my sight on the depth indicator as well, which gives you also auditory cues as you're navigating. So here I'm now shortening that virtual implant, and the reason is I have selected an implant of non-self-tapping characteristics for this case, and also because I have the condensation of the bone obtained both laterally and apically. So I proceed to tap, and to do that, I need to calibrate my tap, and I am going to fully navigate the tap in place after I check the accuracy of that calibration. The only person that truly is looking at the patient is my assistant, who is assuring that there is good fluid control. And again, real-time visualization of the adjacent tooth, of the sinus cavity, and the implant, the guiding pin demonstrating the accuracy of the positioning so far. So now I proceed to the implant placement. We're going to first calibrate this implant before I proceed to fully navigate it in place. And you can appreciate that, you know, of course, I am only looking at the computer as my assistant is looking down at the patient. But you can see the real-time verification now of the implant placement. And we can now see the condensation of the bone obtained in the sinus cavity. In the second case, we'll review that of delayed implant placements. Our patient was referred to our practice as she was in need of same bilateral replacement of her posterior function as she was missing multiple teeth. And with it, she requires some reconstruction in preparation to the implant placement. So when Linda comes into our practice, she has an infection on both number 12 and number 13. Both the teeth are hopeless and they need to be extracted. And at this point, Linda is ready to restore her posterior function, which she has lost for so many years. So we proceed to obtain the CBCT, and you can appreciate the bilateral pneumatization of the sinus cavity with a residual bone height of 2.32 millimeters on the area of number 3 and of 3.47 millimeters in the area of number 14. So with this residual bone height, I proceed to do bilateral sinus augmentation. This is the CBCT at 6 months of the sinus augmentation in preparation to the planning of the placement of the implants and the implant placement. So with the CBCT, I imported the DICOM file to the navigational software, and you can appreciate that I did not use in this case an optical surface scan. The software has virtual crowns that we can use for planning. So I am planning for an implant supported bridge bilaterally on the maxilla. This is the cross-sectional views of the planning on the implants on 3, 5, number 12, and on number 14. So after I complete the planning on both areas, I proceed to fully navigate the implants in place simultaneously. And 4 months after the placement, the patient is ready to have the uncovery of these implants and receive the final restorations, which were delivered by her restorative dentist. And we can appreciate here the attachment loss that is significant on the mandible, in addition to the edema and erythema on the papillas. That is because this patient is diagnosed with oral lichen planus, which is being managed, yet this is a topic of a different lecture. So she's fully functional, she's extremely happy with what she's seeing, and I love to point at this panoramic radiograph. And the reason is, just before I started using navigation, so more than 3 years ago, I will have done this case with a study guide. I love the study guides. I use them all the times before navigation. But we know the drawbacks of a study guides. You know, they're bulky, you have to use long drills, long sleeves. Well, that is a challenge in this case because my patient already has restricted vertical access. So if we add to that the restriction with a study guide, it will be a very challenging procedure for me. I don't think I will have been so accurate in the placement of those implants on the area of number 3 and 14. So how does dynamic navigation overcome that? Well, the patient still has the restricted vertical axis, yet if you locate the tip of your implant on the center long axis of that plan, and you start in an angle, as you're acquiring vertical axis, you can correct the angulation in alignment with your restorative plan. So again, it's a great way to overcome restricted vertical axis, which is a limitation with the study guides. So the patient is fully restored. She's extremely happy with her function and her aesthetics. Now, before we move on to a different series of cases, I like to point out a great utility that dynamic navigation and particularly the software has to offer. So when we have a very irregular sinus cavity, either because there is variable bone thickness or because we have a very narrow pneumatized sinus, we can outline the window of the sinus cavity following the available anatomy. And that is facilitating the access to the sinus floor and also preventing any possible damage to adjunct teeth, in particular when we have very narrow pneumatized sinuses. We can appreciate that on the upper cross-sectional view, I am planning this case as a transcrestal approach because I do have a residual bone height of 5.1 millimeters. But at the same time, I wanted to plan it through a lateral window in case I needed to do a simultaneous approach. Ultimately, I completed the case through a transcrestal approach. I did a bone graft. I combined the technologies, the osseodensification technique with the dynamic navigation to complete the case. So let's move on to a different series of cases. Now let's talk about an immediate anterior implant. So my patient was referred to me as she lost her crown as she was eating toffee at the fair on her lateral incisor number 10. So the restorative dentist was wondering, can we replace this or retain this tooth, or do we need to replace it? So we can appreciate here, she has a high smile line. She has a black triangle between number 8 and number 9. She has discoloration on tooth number 7 and minor misalignment of tooth number 23. So intraorally, the tangent or the gingival margin progression from 6 through 11 is even, with 1 millimeter discrepancy on number 7. The mesial-distal space on number 10 is just shy of 6 millimeters, matching tooth number 7. So radiographically, we have a beautiful long root. I want to save it. There's no pathology around it. So what should we do for this patient? What is the best option? So we review multiple options. We review retention and we review replacement. So let's talk about retention. Before retention, we talked about orthodontic extrusion, and the patient totally said, I don't want to have orthodontic therapy. So that option was a no-no for her. So let's move on to the retention of the root via crown lengthening. If I was to do crown lengthening only to tooth number 10, I will end up with a long elongated tooth in comparison to the opposing number 7. So that option was not an option of choice. She has a high smile line. This is the static zone. So if we do the 6 through 11 crown lengthening, I will run into a challenge as well, as we have already recession starting on number 6 and on number 11. So doing crown lengthening to all 6 teeth will provide me with more recession across. So that option did not really work as well. So after much conversation with the restorative dentist and the patient, we opted that the best option for her will be to do an immediate implant, an implant supported restoration. So we're going to follow the same steps. The first thing we're going to do is we're going to obtain the CBCT, and we're going to also obtain an optical surface scan. And our lab partner will create an ideal virtual plan for the area of number 7, matching the area of number 10, matching number 7. So we incorporate the DICOM file and the STL file into the navigational software, and we complete the plan. We proceed to the extraction, and we initiate the navigational procedure. So remember, the first step, which is crucial, is the trace registration. And the trace registration is how we're registering the patient's jaw to the CBCT. So we're tracing 100 points per landmark chosen to obtain an accurate registration. We will verify the accuracy after we complete the trace registration. And then we're going to calibrate the drill axis, the drill tip, and we will verify the accuracy of the drill tip. Now we're going to initiate the osteotomies. I start with a side cutting burr on immediate implants to obtain primary stability. And I am fully navigating this, as you can appreciate, following the target view on the left. So I decide to change the length of the virtual implant or the actual osteotomy, because with the pilot drill, I was not acquiring primary stability. So I, on the spot, with minimum, time changes to my procedure, I changed my plan. And you can appreciate the real-time visualization of the adjacent teeth in close proximity to my osteotomy. But I'm very accurately navigating both my osteotomy and my implant placement. So now we're going to have, of course, the implant in place. And at 2 weeks, the tissue is doing fantastic. I did not put a provisional on the implant because my insertion torque was just 20 Newton centimeters. So I put a bonded provisional, and at 4 months, I proceed to do an uncovery, and I added connective tissue to enhance the soft tissue contours on this implant. And I do put back the bonded restoration, and we see that at 3 weeks, the soft tissues are doing fantastic. The patient is feeling well. And at this point, we start, or the restorative dentist starts the restorative phase. And one of the things that I expressed at the beginning was that the patient disliked the discoloration of number 7 and the black triangle between number 8 and 9. So the restorative dentist starts working with bonded composite, no edge, just to demonstrate to her what she could do with a veneer on number 7 and by closing the black triangle between 8 and number 9. And she starts working with a screw retain provisional on number 10, which we totally dislike, but the patient seems to be very happy with what she's seeing so far. We can appreciate the screw axis in very nice alignment with the jaw curve. And yet the patient, again, is extremely excited about what she's seeing so far. On the next case, I will be showing you that of an immediate, not an immediate, actually a delayed second molar implant. And so why am I showing you a case like this? This is just a single implant, yet it is on the second molar position where we have restricted vertical axis, which is problematic. But most importantly, because I want to highlight in this case, 2 of the features of this technology. So our patient was referred to us to replace tooth number 18. And he has had already multiple implants placed on, in previous years and by previous dentists in different countries, by the way. So he has a separate issue of problems that I'm not going to talk about today on that side. So 3 images illustrate 2 of the features that I will be addressing today. On the upper right hand corner, you can appreciate the horizontal projections of the fiducials that are related to the Navibite. I will expand on the Navibite just shortly. On the lower right, we can see the ability to load multiple optical surface scans. So the pink STL is my plan for number 18, and the purple is the occlusion, the opposing arch in occlusion for the patient. So what are the benefits of being able to load multiple optical surface scans? Well, first, we can verify the patient's occlusion, as you can see here. Second, when we are planning in different softwares, let's say Blue Sky Bio or Clean Check for clear aligner therapy, which I had to omit some cases because of the time constraints, but it's great, a great tool when we're working interdisciplinary with ortho, placing implants to use for tracking. So yes, I plan with Clean Check, and I bring the STL into the Navident software to be able to accurately navigate my implant for the orthodontist. And of course, the other benefit of loading multiple STLs is for the fully edentulous workflow, which I will be present to you in the next case. So what is a Navibite? A Navibite is a block that contains embedded fiducials for registration. It is actually very useful for patients who are partially edentulous with not enough teeth for registration, either because they don't have enough teeth or because the teeth present are loose. So it is stabilized with a bite registration. Ideally, it should be radiolucent. So if any of you in the chat can give us suggestions on a good radiolucent bite registration, I will appreciate that. So the Navibite again provides us the ability to do what is called point pairing registration. So you can see here the patient has the block in his mouth as well as the jaw tracker, which is bonded with dual core composite, no edge. And I am selecting here the landmarks for registration. I have natural teeth in combination with fiducials from the Navibite, which are recognized by the software. I could have done this case just with the natural teeth, but I wanted to show you the flexibility of using the high contrast landmarks, the natural teeth as fiducials, internal fiducials, and the external fiducials in the Navibite. So I navigate the implant, And I proceed to start working with an anatomical healing abutment. The tissues are closed around the abutment and the implant is in place. I did omit also another slide from this case related to the fragment of the tooth that is present on the mesiobuccal aspect of number 19, topic of a different also lecture. At the 3-week post-op, we can appreciate how well the soft tissue is doing. And again, I wanted to highlight in this case 3 things: the ability to work in areas with restricted vertical axis, as it is on the second molar. Second, the 2 features, the Navibite, and as well the ability to load multiple optical surface scans or multiple STLs. In the next case, by the way, this case was initiated before the pandemic started, and we hope to complete it once we are able to resume back our work in the office. Here I am going to highlight 2 important features. One is the bone anchoring tracker. Second, the ability to load multiple optical surface scans or multiple STLs in order to be able to do the virtual full arch navigated implant supported restoration planning, so a full arch case. So what is a bone anchoring tracker? A bone anchoring tracker is an optically marked tracker that is affixed to the maxilla or mandible through fixation screws. And where do we want to use a bone tracker, a bone anchoring tracker? It is quite beneficial on patients that don't have enough teeth where we can affix a tracker with composite. It is also very useful when there are not enough, basically in fully edentulous cases, as I will be presenting shortly. And last, in my opinion, it is a tremendous aid or help in cases where the stability of the tracker is paramount. And that is in cases of general anesthesia, where we don't want to have an accidental dislodgement of the tracker during surgery. So the patient, our patient Julian, was referred to our practice. The referring dentist reports a long span bridge from the area of number 4 to number 15 that is actually decayed and is not restorable. So we have on the mandible, periodontally hopeless teeth number 20, 21, and number 28. So we want to obtain the diagnostics. We start with extraoral photographs, intraoral photographs. We obtain a video reflecting the patient's facial and profile views. And per the recommendation of our lab partner, Lars Hansen, we want to make sure the patient is counting from 55 to 70. And he's pronouncing the letter M, the letter F, S, and V, so that he can locate the position of the incisal edge on the DSD software, as well as locate the curve speed. So on the upper right, we have the CBCT. I get asked often, what is the recommended field of view? Well, for a full arch case, you need to have a large field of view on the CBCT. And the reason is we need to have anatomical landmarks so that we can register the STL of the virtual anatomical bone reduction reference guide into the DICOM file and then proceed to the planning. On the lower right, we obtain an optical surface scan. And once we acquire all these diagnostics, we're going to send to Lars Hansen, our lab partner, who has worked tremendously on this case. He's going to incorporate the MP4 files, the JPEGs, the DICOM, the STL file of the CBCT, the DICOM file of the CBCT, and he's going to create the DyNav immediate prosthesis. So we proposed to the patient 2 separate plans. We proposed a bimaxillary fixed detachable implant supported restoration. And the second option was to retain teeth number 22 through number 27. Well, our patient has always loved the appearance of his teeth and his function. And he knows that with his class 3 malocclusion, which is edge to edge, likely the best option of choice will have been to do a bimaxillary workup. However, he prefers to retain those natural teeth. So we go with option number 2, maxillary fixed detachable against mandibular bilateral fixed implant-supported restorations, implant-supported bridges. So Lars Hansen completes the dynamic media prosthesis. He provides us with two different options. We discuss an all-on-6 for the maxilla or an all-on-4. And in order to now complete the planning, we proceed to place fixation screws, which are going to be used as fiducials on the maxilla and mandible. And why am I doing this? Well, for a full arch case, I could perfectly fine have used the natural teeth here. However, if I remove the teeth and I proceed with the bone reduction, I still need to rely on another source of registration in case, and only in case, that I lose the accuracy during the procedure. So those fiducials will be used as a backup plan to do the trace registration. And on the mandible, we added those fiducials to improve the triangulation of the registration. So Lars Hansen completes the dynamic media prosthesis for an all-on-4 solution on the maxilla against the opposing natural teeth in the mandible. And this is the final plan for the mandible implant-supported bridges bilaterally with immediate implants on 21 and number 28. So we select for the mandible the combination of landmarks. We have natural teeth and we have the two fiducials to optimize the triangulation. So Dr. Manuel LaRosa is leading the mandibular phase of this case. He's applying or fixating the bone anchoring tracker after he has released a full thickness flap. You can appreciate how the tracker is out of the way of the clinician, preventing dislodgement of this tracker, especially again in cases of general anesthesia. It is a quite of an important use. So the osteotomies are navigated and the implants are fully navigated in place simultaneously. And he proceeds to have also, or to place a bilateral LPRF bone graft for augmentation. So now let's get to the exciting part, which is the maxilla. So you can appreciate here in blue, this is the STL of the Virtual Anatomical Bone Reduction Reference Guide. And it's a reference guide because it's telling me exactly where do I need to do the bone reduction. I am not going to use, and I don't need an analog bone reduction to do this procedure. So in yellow, you can see the projections of the jaw cuts that will be done with a piezo to complete the bone reduction. And in pink, we have the STL of the prosthesis. So from the profile views, you can see the projections in yellow of the jaw cuts that are basically there to be done for the bone reduction guide. And they're distributed 10 millimeters apart from each other. And the right, you can see the distribution and the location of the implants for an all-on-4 restoration. We have number 4 and 13 tilted, and number 7 and 10 in a long axis. And again, on the left, we see the Virtual Anatomical Bone Reduction Reference Guide. So the maxillary plan is completed. Lars Hansen, again, who has diligently worked in this case in collaboration with us, has put prosthetic pins to the STL of the prosthesis to stabilize the prosthesis and assure the proper alignment when we're doing the conversion. In purple, you can see the prosthetic pins, one on the right, one on the center, one on the left. In yellow, you can see the distribution of the implants. And on the axial view, you can appreciate the jaw cuts distributed 10 millimeters apart. So the distribution of the implants for 4, 7, number 10, and number 13. So at this point, the plan is complete and we're so ready to complete this case on the maxilla. So I have selected the landmarks for trace registration on the high contrast landmarks, which is the natural teeth. And I have also selected the fiducials that are placed on the maxilla. And that is in order to, again, have the backup plan once we reduce the bone and once we have extracted the teeth. So again, in this case, I wanted to highlight two features. One is a bone anchoring tracker, and two is the ability to load multiple optical surface scans so that we can complete a virtual full arch navigated implant supported restoration. In the next case, it is that of an immediate molar implant. Our patient was referred to us as she developed recurrent caries after she had had 10 years ago endodontic therapy, a buildup, and a crown. So unfortunately, you know, at this point she has recurrent decay. Her restorative dentist proceeds to remove the existing crown. She does caries control, and she deems the tooth hopeless. So she calls me, she sends me an x-ray, which I received, and this is what I got. I get this x-ray. And I am looking at the radiograph thinking, why am I taking this tooth out? So I questioned her, and of course I had not yet seen the patient. And she tells me, you know, yes, we all agree that she has ideal crest of bone, nice separation of the roots, beautiful endodontic therapy, absence of periapical and periradicular pathology. But yet she said, do the evaluation and you tell me. So I did the evaluation, and sure enough, she had caries that was extending 4 millimeters subcrestal on the mesiobuccal aspect of tooth number 30. So we don't want to do a crown lengthening at that depth because we will be compromising the bone support to the adjacent teeth. So yes, I agree that this tooth needed to be extracted. So I proceed to obtain a CVCT and plan for a taper effect wide neck implant given the space that I have. So in this case, what I am highlighting is one of the great benefits of dynamic surgical navigation. But this particular feature that I will be highlighting is unique, currently only to Navident, and it is the ability to use all our handpieces. The system is handpiece independent. That means I can use my high speed, my low speed, my piezo. So for this particular case, and in immediate implants, I like to drill through the teeth. I like to actually create my occlusal axis with a high-speed handpiece, which I am fully navigating through my plan. And I do this because I don't want to have recoil from my implant drills, which are rather expensive. I don't want to ruin them that way. So after I create the occlusal axis, I now use my pilot drill to create my pilot axis. And you can appreciate it here after I have removed the crown. Also, you can see some of the remnant of the composite that is placed on the area where the caries is extending 4 millimeters subcrestal. So I decide to change the plan. Surprise, right? So I changed the plan only because this is an immediate implant. I cannot afford to tap. I want to use a self-tapping implant. So I went to a bone level taper implant for the case. So the guiding pin is demonstrating the accuracy of the osteotomy so far through that tooth. And from left to right, you can appreciate the implant in place with the bone graft surrounding it. In the center, the peak abutment holding onto the collagen membrane, and the tissue is closed. Dynamic navigation can certainly optimize partial extraction therapy. There will be no estimations, only accurate surgery. And to me, this is powerful. I think that it will be the perfect synergy. So I get asked very often, how do you verify the accuracy of your implant placement in your practice using this technology in your hands? Well, in the case of Navident, there is a feature embedded within its software called EvaluNav. EvaluNav provides us the deviations that during the plan and the placement. And that is by loading the pre-op CVCT and the post-op CVCT and then registering them into each other. EvaluNav provides us the deviations at entry, at the apical level, and also the angular level. So in this particular case, I place an implant on the area of number 4, and you can appreciate the deviations. At entry, we have 0.35 millimeters, at the apex 0.43 millimeters, and the angular deviation 1.81 degrees. You know, how much better we want to be. Can we reproduce, or can I reproduce these deviations in our practice using either freehand surgery or study guides? You know, I don't think so. So what about in this case where I did an immediate implant on number 8 with even better deviations? We have 0.13 millimeters at the entry, 0.04 millimeters at the apex, and 2.19 degrees of angular deviation. 0.04 millimeters is 40 microns. I am here measuring my deviations in microns, and we're so used to planning and placing implants in millimeters. So to me, that is super exciting. And I actually have to tell you that these deviations are to me unreal. I don't do follow-up CBCTs for my patients only because there's no need. I don't find a need to do this, but I wanted to take a couple of them so I can demonstrate the value of EvaluNav, and it is very exciting. So with these deviations, I decided that I wanted to compare my deviations to those that have been published. And you can appreciate here that the values speak for themselves. I am doing so much better for my patients at all levels. Let's look at the anterior case where, again, I obtain even better results. We can appreciate here how this data demonstrates how this technology improves the accuracy of our implant placements. And it is reproducible every single time, by the way. So due to time constraints, I cannot expand too much on the benefits of navigation, but I will definitely highlight them. We went through them as I was presenting the cases. So the first benefit is the improved accuracy as is demonstrated in the in vivo publications. Second, no longer we need to use a study guide. Again, I am sure a lot of you have used a study guide. I used to use the study guides a lot. And they're great, but they do have quite a bit of drawbacks. The two most important, in my opinion, is the restricted vertical axis and also the fit. And the fit is relative because it does depend on the manufacturing. So a good manufacturer study guide will be most likely very accurate, but the problem is not always that is the case. And a poorly fitted study guide will lead to inaccurate placement of implants. And we of course know that we don't have the ability to change the plan within surgery on the from the horizontal standpoint, yet yes from the vertical. From the vertical in dynamic navigation, it is crucial for me to be able to do that, as I demonstrated in transcrestal sinus augmentations. Now, the software is very easy to use. I can only speak for Navident, which is what I use. The software is easy and it is very intuitive. Versatility. Dynamic navigation is truly versatile. And why is it? It is because it is CBCT independent, it is implant system independent. I can change the plan within surgery, and you saw me, it was with very minimum delay to the procedure, and in real time. I am changing in real time something that I cannot see with the study guides or freehand surgery. And last, of course, uniquely to the Navident is the handpiece independence, as I demonstrated in the immediate implant placement. So additional benefits include real-time visualization of the anatomical structures. We saw in the different cases, you were able in real time to see the sinus cavity, to see the adjacent teeth. What about the real-time verification of the restoratively driven implant osteotomy and implant placement? You also saw that as I was proceeding with the osteotomies and the implant placement. The ergonomics, this has been a game changer for me in our practice. Our position is, the posture is always very straight, the hands are relaxed on the side of the patient. This is something that I wish we could use for all our surgical procedures. What about the patient's experience? It has definitely brought a wow effect to our practice. The patients are mesmerized by the technology and by the integration of the digital workflow. So I get asked a lot why you chose the technology that you chose, why one versus the other. Well, I will tell you that is because it puts together all the benefits I just spoke about. But in addition, because this technology, Navident, is fiducial independent. To summarize, if we don't need to use an external fiducial, we don't need to have a stent. If we don't need to use a stent, that means we don't have the human error of making the stent, which can be altered between the CBCT and the surgery. So eliminating the stent is a great advantage of fiducial independence. And the second advantage is we don't need to take a secondary CBCT. That decreases the radiation exposure and many times reduces the number of visits for the patient. So with one CBCT, I can plan, I can diagnose, I can plan, and I can place my implant. The second advantage over the other technologies is that these, the Navident, and only for Navident currently, it is handpiece independent. And that is very critical for me. I want to have the ability to interchange, to exchange my handpieces within a surgery. I want to be able, as I show you on the immediate implant, to use my high speed and my low speed handpiece and navigate them both. I also I need to have that flexibility on the full arch planning and implant placement, because I need to do a bone reduction guide and I want to navigate my jaw cuts with my piezo. I cannot do that with other technologies. Now, what about one of the subjective reasons? So the first two are truly objective reasons based on the technology. Let me give you a couple of subjectives. One is the portability. The system is portable, and to me that is critical. I can move myself, this technology, from one room to the next, from one office to the other. We have multiple clinicians and 2 different offices. I need to have that flexibility. So clinician support, another subjective, but very important to me. This is a technology that comes with a team that truly believes in us delivering optimal patient care and truly believes in and helping us and want to help us in this journey of navigation. And I really, really have appreciated that. And the last objective reason for its accuracy is demonstrated on the in vivo publications. So again, you know, I don't see with all these benefits why we should be doing dynamic navigation, or why we should not be doing procedures, implant placements, transcrestal sinus augmentations, immediate implants, PET procedures without dynamic navigation. So I love quotes. This one in particular by Khalil Gibran. Progress lies not in enhancing what is, but in advancing toward what will be. And we all have seen progress. We went from freehand surgery to study guides, and now to the next leap forward, dynamic surgical navigation and robotics. This is our team. I am very proud of them. They're my extended family. They're hardworking individuals, very talented. I miss them dearly during this pandemic and hope to resume practice, hopefully in the next 3 weeks, to see them again. You can come, of course, and visit us after the pandemic is over. You're more than welcome to come in. Maybe we have to keep still some 6 feet of distance, but we can all share knowledge, or maybe you can do a virtual tour. And before I conclude, I'd like to tell you that this technology has definitely improved the accuracy of my procedures. And not only that, but has improved the hand-to-eye coordination and my spatial orientation. And let me tell you what, the accuracy is reproducible for sure. And I am happy to answer any questions at this point.
Silvia, thank you very much for this beautiful lecture.
Thank you, Paula.
It seems everything is very clear because I can't see any questions in the chat box.
All right, well, if anybody has any questions, please go ahead and add them so we can actually have a little Q&A. I can certainly expand on any of the cases if you're curious about the benefits or the technology per se.
Here we have the first question. Are the newer jaw tracker available?
Are there what?
The newer jaw trackers available?
Available. Yes, the bone anchoring trackers. You know, that is a good question. I think they are. We need to probably direct that question to Beth. As you know, I am one of their beta testers. So yes, I have been using them actually since the fall. And I think they should be available now to all. Beth, can you please give us some input on that?
They're in production at this time, and we are sending out some, but it'll be very soon when they will be out there for everyone.
Perfect.
Yeah.
Excellent. Thank you.
You're welcome.
All right. Any additional questions? You made my life easy. All right. Anything that you're curious about, that you want to learn about? Nobody?
Okay. That's.
Well, let me tell you something that I have to say. What's up?
You were very thorough. You covered everything. You answered the questions.
Everything is clear.
Well, let me tell you one thing that I am very excited about. And again, I think I could have spoken for probably 4 hours. I had to omit a lot of cases. I have many more cases in ortho and again, full arch planning. And I'm definitely extremely excited how this technology has continued expanding its applications, and it continues creating the solutions to clinical challenges. You know, when we think about the emerging applications in the past, we were only able to do just the implant placements, right? When I started using the specifically Navident, it was just for placement of single implants, or not for single, but it was just for implants. And then the expansion, you know, like a big boom occurred, right? And now we have, you know, the expansion to the endodontic field, and which was once emerging, now is happening. Truly also for the full edentulous workflow that was once emerging, and this is still in the works, but I will tell you, it's actually here. Like I show you in that case, I am super excited because I know that now we're going to completely eliminate any analog portion of the flow, and it will become fully digital. And when I think of digital dentistry, most people ask me, you know, why digital dentistry? Why making your life more complicated? And my answer has always been, it's never been more complicated, because digital dentistry has made us more accurate. So it depends on which, you know, what role you want to play. I think that it is actually more intricate, and it makes us more accurate. Digital dentistry has improved our communication amongst clinicians, with the patient, with our lab technicians, and certainly has minimized any improvisations and reduced complications. So I think, you know, this quest is not finished, and I think it's very exciting because from here we're moving to robotics, and you know, it's something that we all need to continue learning. So I encourage everyone who's yet still at the era of freehand surgery to definitely move on to guided surgery, because with freehand surgery we cannot reproduce accuracy. And like with, you know, of course, the study guides, but better now with dynamic navigation.
There is another question here, Silvia. What was the name of the lab that you used to plan your cases?
It's Dental Design Solutions, Lars Hansen. And I think he's maybe in the chat box. He should be present. Yeah, he's awesome. I will tell you, and to just, you know, summarize one thing, you need to partner with a technician, with a lab that truly understands digital dentistry, that truly understands the workflow, because, you know, once you commit a mistake on an initial step, they actually are cumulative, and they exponentiate. So you have to work with somebody who has done due diligence to have education enough, you know, to learn well the digital workflow, that is very active in conferences, that is actually active in learning these techniques. All right.
Okay.
That's it for the questions.
I cannot see the chat box myself, so I will let you just tell me if there's anything else.
Oh, okay. Yeah, so if you let Navident know, let us know. You can email me. You have my email. If you let us know who your lab is, we can provide them with a planning version of our software, so you can work a little bit more smoothly together through the process. So happy to do that for you. Here's Lars Hansen's email. And by the way, that software, the planning version, is $1,000 value. Okay. All right, so if there's nothing else, I would like to just mention to all the participants that very soon you will be receiving an email to the email that you registered with that will contain a link to your CE documents, or you can copy and paste the link here. It will also have a recording of this fantastic webinar, thank you, and a link to our upcoming webinars in our series. As I mentioned earlier, Dr. Vila will be doing her presentation on dynamic navigation for microsurgery in private practice, and Sylvia LaRosa will be her moderator. Our next webinar, May 6th, Bobby Nadeau, again, optimizing ergonomics with dynamic and microscopic dentistry, and then several others, the last two being more related to edentulous cases and using All-On for All-On-X and pterygoid implants. So you can check that out. The link will be provided to you with the CE link. So thank you so much. Thank you, everyone. Great job as always, Sylvia. Very informative. And Paula, it was a pleasure. Thank you for moderating. Have a good day, everybody. Thanks.
Thank you. Bye-bye.
Thank you so much. Bye.